Hello, everyone. Thank you for joining us for today's Davis E-Lecture on a rainy day in Chicago. Glad you can join us indoors to avoid this weather if you're local. In a moment, today's discussion moderator, George Herbert Jones Distinguished Service Professor and Chaz Faculty Director, Jean Marsh, will offer brief opening remarks and an introduction of today's presenter, Associate Professor at the University of North Carolina at Chapel Hill, Valerie Lewis. If you have questions during the presentation, please type the questions into the Zoom Q&A pane or the chat section for answering post-lecture. The chat function will be open for questions following the presentation. We will do our best to answer all questions after the discussion between Doctors Lewis and Marsh. A recording of today's webinar will be featured on the Chaz website as well as the Chaz YouTube channel, which can be found by searching YouTube for the Center for Health Administration Studies. And now Professor Marsh will introduce today's presenter.
Good afternoon. It's a great pleasure to have all of you with us today, and it's my distinct pleasure to introduce our speaker, Valerie Lewis, PhD, who is an associate professor in the Department of Health Policy and Management at the UNC Gilling School of Global Public Health. Professor Lewis focuses her work on topics of great interest to those of us at the Center for Health Administration Studies. She looks at healthcare payment and delivery reform, healthcare organizations, racial and socioeconomic disparities and outcomes, integrated healthcare delivery, and social determinants of health. Today, she's going to be discussing the topic of integrated care and social determinants of health with her presentation entitled Navigating Rough Waters, How Healthcare Providers Work to Address Patient Needs. Thank you. Take it away, Professor.
Thank you so much. I'm very honored to be here. I mentioned to Dr. Marsh before this call that in addition to Chicago's wonderful reputation in this particular field, I trained in sociology, where Chicago also has such a stellar reputation and history for impacting our field. So I'm very honored to be here. As Dr. Marsh said, my talk today is a body of work that I've done on looking at the integration of healthcare and social determinants of health. I'm going to just situate that work within some of the big questions that kind of motivate all of my research. One is, what is the best way to organize and pay for healthcare? There's been a lot of work on payment models, and I think especially my colleagues in health economics have done a great job figuring out the payment side and working on new payment models. So the emphasis in this that I work on is largely around how to organize healthcare. Most kind of new healthcare models really rely on the organizations that build our healthcare system to be doing work in newer, different ways, and looking at how to best organize those providers. A related then second question is looking at who should do what. A lot of reforms or changes that we're trying to make in healthcare or integrating across healthcare and social services require everyone to work together in new ways, work across boundaries. And we haven't really figured out across a lot of domains who should be doing what work and how. This includes thinking about what should health insurers be doing, what should healthcare systems be doing, what should be left to individual providers, practices, or small organizations. And as I'll present on today, this also applies to, as we look at integrating medical care with care for social needs, who should be providing what services and how to organize that. And the final large question motivating my work is, how do we ensure that healthcare policy, especially payment policy, promotes equity alongside quality and efficiency in healthcare? Or at a minimum, how do we ensure those policies don't make things more inequitable? So some acknowledgements before I show you more of the research. Collaborators on the work I'm showing you today are Hector Rodriguez at Berkeley, Ginevra Murray at NYU, Joelle Jung, who's now actually in Texas Medicaid, Teresa Fraze at UCSF, and Amanda Brewster also at Berkeley. And funders that have funded the work I'll be presenting today include ARC, NIA, the Donahue Foundation, and the Commonwealth Fund. So we're very grateful to the support for this work. So a bit of motivation. In this group, perhaps I'm probably preaching to the choir a bit on how and why we should care about integrating care for social needs in medical care. But as background, we have known for a long time that healthcare outcomes are actually only a small bit predicted by the healthcare that people receive. And healthcare outcomes are much more predicted by other things outside of healthcare, such as individual behavioral, social, or economic factors. And depending on how you estimate that, those estimates range from 40 to 90% of health outcomes are actually attributable to things outside of what we'd consider traditional healthcare. We also know these factors affect quality of care and costs of care. So some classic examples, particularly if we're thinking from the very healthcare-centric side, is when we look at things like control of diabetes or patients getting readmitted to the hospital. There's many things about a patient's social life, their housing, their economic circumstances that impact those outcomes, regardless of the quality of care they're receiving within the medical system. As a result, there have been widespread calls to address social needs. These have been to healthcare providers. These have also gone out to payers, and policy institutions have also put out these calls to really integrate social needs into healthcare. As you'll see, all of these kind of start in 2016, 2017, and the work I'm presenting today, we actually started a little bit prior to that. So I'll talk a little bit kind of through the arc of our work, and as there's been a kind of proliferation of interest in this field, what that means for where the research agenda should go more largely. A second part of the motivation here is that in healthcare, there's a lot of movement towards new payment models. And new payment models may be a way to, proponents of those models hope that they will spur more focus in healthcare on upstream determinants of health. The most prominent of these models has been accountable care organizations, although there's several others. But ACOs are providers that are held accountable for both quality and cost of care for a defined patient population. And since social needs and risks affect both health outcomes and costs, we would anticipate that participating healthcare providers may be more motivated to address social needs. In addition to that, some states through their 1115 Medicaid waivers have explicitly built integration into these kinds of payment reform programs, and I'll return to this specifically at the end. So there's a lot of reasons we would expect that these payment models might provide a vehicle for healthcare providers to do more of this integration work. The empirical work I'll present on today come from three main data sources. The first is the National Survey of Healthcare Organizations and Systems. This is a trio of surveys that went to healthcare systems, hospitals, and primary care practices. I'll focus on the primary care and the hospital surveys today. We conducted it in 2017 and 2018, and there's a second wave now in the field. So I'll be presenting data from the first wave, and depending on which of those surveys, the response rates were 48 to 60%. The surveys are unique in that they're some of the first surveys, particularly for primary care practices, that represent a comprehensive national view of primary care practices and their capabilities. And I'll present some data out of that today. The other two data sources that I'll be drawing on are in-depth site visits and semi-structured phone interviews. I have a little bit more information on those on my next two slides. phone interviews, I've led with my team phone interviews at over 70 unique ACOs, kind of over a decade-long period through a number of different projects. We have some modules that stay the same and some that kind of change out for a particular topic. In terms of data we're presenting today, we had one set of these interviews we did specifically around social services integration, and we went specifically to ACOs that were doing quite a bit of work in the area of trying to integrate care. We're pairing the phone interviews with data collection from site visits. These are longitudinal, basically case studies we have done. In total, we've done over 20 site visits. The data that I'll present today come from 11 of those. We focused in 3 organizations we identified as high-performing organizations in terms of their integration of medical and social care out of our phone interviews. And our team would go on site, interview people at a variety of levels at the healthcare organizations, as well as the community-based organizations they were working with to integrate medical and social care. And we also observed a number of meetings or things that happened. So we observed care team meetings, board meetings, finance meetings, and meetings with kind of partner organizations. So those are the methods I will present. If you have more questions on any of the methods, I'll return to the end. I put these all together so that I can focus on the kind of empirical results. So the earliest work we did on social services integration was starting in kind of 2012, 2013, and 2014. And we were interviewing at that point mainly on how were providers undertaking new payment reform. And a handful of providers reported, without even being asked about it, their work on addressing social needs. The most common needs they discussed focusing on were housing, transportation, and food. And there were some really exceptional examples in the early work. For example, there was one organization we spoke with that realized they were having a problem with discharging patients from the hospital. When patients were homeless, they had nowhere to be discharged to, so had to be kept in the hospital longer. So they put together a pretty innovative program with the local housing agency, where the housing agency reserved a certain number of units that could be solely for this healthcare organization's patients. And in the contracts they put together, the housing agency agreed to relax some of the terms of, the requirements for being able to be in that public housing. There's pretty strict requirements sometimes of who can be eligible. So they loosened that in order to kind of like work with the healthcare organization to reserve those units. In another really interesting example, there was some non-emergency medical transportation, and the healthcare organization was working with the transportation organization. This was in a rural area, so it was a little bit like, it was not Uber, but you could think of it as structured a bit as an Uber situation. And they provided the drivers for this non-emergency medical transit with essentially health coaching training and information, so that when they were taking patients to or from appointments, the drivers were intended to be kind of supporting the patient's need as part of the transportation. So these are the kinds of examples that got us really excited for like what was possible under these new models and the creativity and innovation that could be brought to this sector. We also identified early on kind of 2 different ways that this work was being structured across medical organizations and social service organizations. The first was what we call a coordinated model, where the organizations remain separate, but they're working to coordinate services. The second was more rare, but we saw more than one, where we call it a fully integrated model. And this is where the board, they were fully integrating at the organizational level, not just at the service level. And this often looked like the local community-based organizations or social service agencies were getting voting membership on the board of a healthcare organization or an ACO, which meant that, you know, how the money of the organization was being spent, the local community-based organizations were having a vote and a say in that. So it's a much more integrated organizational structure rather than just a service delivery integration. When we went to the field with our national survey of healthcare organizations, we asked about first screening for social determinants of health. We asked about 5 social determinants. These are the 5 that were included in Medicare's accountable health communities and are often identified as 5 core social risks or social needs to be screening for. On the left side of this panel is primary care practices and the proportion of those that are screening for each of these needs. And the right side are hospitals. Interpersonal violence is in both cases the most screened for. It's interesting showing people these results, whether these are encouraging, or whether this is a glass half full or glass half empty situation. Some people read this as relatively high rates of screening. I think especially in primary care practices, these are pretty low rates of screening. And we have one more where we look at the total number of these needs that are being screened for. So if we look at all 5 of them put together, it's roughly 1 in 5 practices and hospitals that are screening for all of these needs in a routine way. We expect that if anything, these are probably liberal estimates. I think there's a bit of social desirability bias, or we didn't kind of go into these practices and hospitals and validate how much they are routinely screening and how well that practice is working. This is simply a self-report on it. So we also found that some organizations are more likely to screen. Among primary care practices, those are federally qualified health centers, practices with more Medicaid revenue, and those in Medicaid expansion states, and also those participating in value-based payment. Among hospitals, actually a lot fewer things kind of predict how much they're screening. The only one that really stands out is that academic hospitals are more likely to be screening. We were interested in this question of the value-based payment that I raised at the beginning, so we did a little more investigation into that specifically. Those results are really interesting. We looked at, so like I said, the practices that are participating in more value-based payment are screening more. But we also looked at some questions included in our survey, basically around the innovation culture of the practice. And this has to do with the barriers that exist to innovation. These are some validated scales from the organizational theory and healthcare organizations literature. And what we find is that the value-based payment isn't really driving the screening. The innovation culture of practices. So practices that are innovative are both doing value-based payment, and they're more likely to be screening for social needs. So we next went to the field with our large-scale project, tracking 3 high-performing organizations longitudinally over a 3-year period. The intent of that project, including like when we wrote the grant, was find high-performing organizations, watch them unfold over time, and kind of report back best practices or what we could learn from the field. That project ended up being, at first blush, rather depressing, because what we found is these 3 organizations that were really well positioned and dedicated to the work, even while we followed them, were very slow to make progress in this area. And we saw the same reflected in our phone interviews. Sites that had both high motivation and strong commitment were not making at all the progress in integrating that we would hope they might. We define high motivation as being under new payment models where, they are being held accountable for costs and quality, where we might hope there is a way to make a business case for addressing social determinants. And strong commitment is, for example, we spoke with a lot of safety net organizations that are very mission driven and very clear on how much social determinants matter and wanting to address them. And the progress being surprisingly slow, we see in a couple of ways. At these organizations, there are very few formal programs or contracts in place, even over a multi-year period. So while there was kind of desire or meetings with local community-based organizations, the actual integration formally setting up services wasn't happening. The second would be inadequately specified contracts. That's a bit of an organization's way of phrasing it. But even when programs existed, those programs were pretty weak or hadn't made much progress or really gotten off the ground. So we shifted our focus to why this is happening. Why are we not seeing the progress we would want to see, even among these organizations that are well positioned to make progress? And we identified three key issues. One around data and evaluation challenges, the second around pathways to partnering, and the third around financing models. Data and evaluation challenge is actually encompass a couple of things put together. One is lack of any data. So healthcare organizations working to address social determinants often lacked even internal data on what social risk factors or needs patients had that would help them, for example, determine what kind of community-based organizations they might want to work with, be that housing, food insecurity, and so on. In addition, healthcare organizations lacked data on the local social service organizations to know what of those organizations were high quality or had the services they needed in order to partner with. It's hard to understate the extreme degree of this lack of data. So for example, at the end of following these organizations for a few years, only 2 were even getting counts of patients that were using new shared programs they put together. So much we're very far from evaluating those programs or, are they working or not? One of those organizations still hadn't even figured out how to count patients using the program. Our most advanced outlier was innovative and doing some great things. They had kind of standardized screening built into the health record. They built a tailored software that could feed data into a social services workflow. And there were care plans shared between healthcare providers and community-based organizations. And those had read-write privileges on both sides, which turns out to sound like a small detail, but very important. Because it means that, the community-based organizations cannot just see what's going on in healthcare, but write things into the health record that then the healthcare providers can see. So if you can imagine, for example, a homeless shelter, getting data on the patients is one thing, but being able to actually put right into the care plan things from that end is another kind of important, an important circle. In terms of partnership development, a big problem was essentially figuring out who should do what between the healthcare organizations and community-based organizations. Healthcare organizations can provide services directly, or they can, we often talk about make, buy, or partner. They can make the service themselves and provide it. They can buy it for somewhere it exists or partner for it. Healthcare organizations were almost all recognize the value of partnering with community organizations, but a lot of them were also setting up their own delivery of services themselves. So for example, we had a hospital system that set up its own food bank in one of the hospitals. And a lot of times that was driven by kind of wanting to do something now, and the process of partnership being a slow one. And this often led to kind of conflict in partnership development. So in the example of the hospital setting up its own food bank, they ended up working with the local food bank, who was rather irritated that they had a lot of long-standing expertise in how to effectively run a food bank, and now the hospital had set up a competing one. And they ended up shifting that model to a partnership model, but it highlights some of these challenges over where should services be delivered, what's most effective, and kind of the challenges in partnering. Those challenges in partnership development are hard to overstate. One of the things we found is that the lack of professional networks spanning the sectors, kind of the social services sector and healthcare sector, had really important implications. So we find in the rest of our work that focuses more in the healthcare sector that when healthcare organizations want to partner, they know who the local players are in order to partner with. So for example, they might have worked together on local, regional quality initiatives, and the local providers know who the local hospitals are or the community health centers, and they at least have some kind of professional networks locally to draw on when they want to partner. That's in a strong contrast to this area, where there are almost no professional networks that exist between community-based organizations, and medical organizations. And what we saw happening in that kind of complete absence of professional networks was that partnerships would form out of personal networks. So for example, in one case, we had kind of a board member on a healthcare organization who also was a board member at a local YMCA. And when the healthcare organization wanted to start some new work partnering, they kind of leveraged that personal tie their board member had to set up programs. I think there's two perspectives on this. One is, I don't think we want this as the long-term solution, and nor is it going to be the most effective solution. But practically, in an environment where it's essentially a vacuum of professional networks, this is a pretty rational response to at least starting some work. It also speaks to the lengths, the slow progress and why that progress is slow, as well as some policies that might promote this that I'll get to towards the end. Finally, financial challenges. We found that there's a lot of challenges to the financing of this kind of integration. First is just the amount of financial support available to kind of develop integrated programs. A second challenge that policymakers are starting to take up is regulations on how medical dollars can be spent. We heard a lot from interviewees about things like Medicaid medical dollars versus administrative dollars. And we had a great example from, for example, a healthcare organization had identified that one patient had asthma that was frequently out of control, and an air conditioner in their home would probably help their asthma stay more in control. They went through months of rigmarole to try to buy this low-income patient a air conditioner. And in the end, we're told they could not use medical dollars to purchase the air conditioner. So the health plan kind of involved in this, it was a Medicaid health plan, ended up using administrative dollars to purchase the air conditioner. But that speaks to kind of regulatory constraints on finances and what we consider medical or not. A final challenge is a lack of alignment on timelines, and those timelines and how financing works with that. Medical organizations, even those under new payment models, are typically working on timelines that are, each year they are being graded on their cost and quality performance. So they have very short timelines versus the social service agencies they're working with generally aren't thinking of impacting patients' long-term outcomes in the next 6 to 12 months. There's kind of a longer time horizon on change. And so getting those timelines into a place where that can work for these two very different operating sectors is a challenge. So just to summarize sort of what we know and what I've presented on those empirical results, is that few healthcare organizations kind of are successfully integrating or coordinating care, even when they're really motivated and committed. And I think that's really important. I don't think this is a problem of, healthcare providers don't care or don't want to do this work. It's other constraints that are impacting that. Another way to put that is the historic siloing in the United States of healthcare from the social sector has major ramifications. And it's almost impossible to overstate the barriers of that historic siloing of care. And we see that both in the formally how these organizations work together and informally in terms of those, professional networks that just don't extend across the two areas. So the next part of my presentation, I'm going to share kind of charting a forward-looking agenda in this area, what we're working on now, what others are working on, and kind of where this area could grow. So there is major interest in this field. In the past 5 years, there has been a proliferation of work and attention compared to maybe a decade ago when we started this work. There's just now almost everywhere you turn, people working to improve the integration of social and medical care. And there's an associated proliferation of studies and publications in the academic literature. What a lot of these look like are pilots of programs or screening, either within healthcare organizations or community-based organizations, Most of them are small empirical studies focused on the organization in question, piloting a particular program in a particular site, and if it works or not, if it's effectively implemented or not. The field is generally hampered by, in my view, two big things. One is, particularly on the implementation side, inadequate attention to the long-term role of organizational partnerships in success of this work. So a great example of this is there is a lot of attention or a lot of, especially healthcare organizations, one of the first places they turn when they start this work is to build screening for social risk factors or social risk needs into the clinical workflow. That's often turned to first because it's viewed as something discrete that can be done within the healthcare organization and can be stood up perhaps relatively quickly, compared to something like developing an integrated program across the healthcare sector and social services sector. So standing up that partnership, developing the program, figuring out how to refer patients and close that referral loop back. The challenge is that the challenge is that none of these things happen in isolation. So once you've screened patients, they need to be referred somewhere. And by building screening kind of in your silo of a healthcare organization without attention to how the referral will work or how these joint programs will work, it's often built in a way that then renders the referral work harder down the line. So while it is true the healthcare organization can engage in the screening, what we've started to see is a lot of resistance even within the healthcare organizations of physicians or other clinicians who are screening but then don't have anything to do for the patient they've just screened. And the patient is housing insecure or food insecure or experiencing interpersonal intimate partner violence, and they have nothing. They can provide no services or no referrals and now have screened them. And there's resistance to that kind of like screening for screening's sake. And so without building in kind of the longer term approach, we're kind of ending up with like stunted development at the screening for social needs phase. The second big challenge of this field is the lack of undergirding theory to really drive, interpret, and guide the field. So what we see in the academic literature is a proliferation of results that are empirical settings specific that aren't necessarily building up to any kind of mid-range theory that can help better direct providers that are working to do this. So for example, when there's a program that is either successful or not successful in one setting, we don't have a lot of kind of larger aggregated, what we call it theory in my field. There may be, but guiding providers on what might work in what contexts and why, so that they can adapt programs successfully from other settings with some kind of guiding knowledge of what might make it work or not. So we kind of have a proliferation of empirical results without a lot of kind of collecting those results together to better guide the field. I think one thing we have found is the critical role of organizational partnerships, and that I think also is being somewhat neglected in this field. So we developed this figure. I'd love feedback on it from anyone who has it. The blue circles represent the types of work that needs to be done to better address social risks and social needs and integrate it with medical care. And the yellow circle represents kind of all of that work that will eventually or initially need to involve partnership with a different organization. So you can see that, payment for social services, there's a little bit of that falls into coverage of social services by health insurance companies, which can be done directly. But payment, there's also payment for these programs for medical providers, which again will involve medical and social service agencies working together. The same is true of data and technology. Again, in that little blue at the bottom, you can see screening for social needs and risks. That can happen solely within a healthcare organization, But as soon as we get to sharing data across settings or shared technology platforms, those involve working across organizational boundaries. And finally, programs and services. There are some interventions that are being built to be delivered solely within healthcare settings, but most of the rest of programs and services involve referral or closed loop referrals, new joint programming or interventions, or care plans that span social and medical needs. And all of those will involve interorganizational relationships. And so understanding these organizational relationships is really critical to advancing this field. And this is really kind of a point at which the field, by not kind of engaging more with what we know about how organizations can work effectively together, is another kind of reason this field is not advancing as fast as we want it to be. Financial models, more work can be done in this area as well to kind of show what are financial models that can work. This is so often cited as a problem or a barrier to integrated care. I've put on this kind of from the most informal to the most successful, what we've seen in our data, from kind of no formal contractor financing structure to lump sum payments, to what we believe are the most successful, but need to collect some more data on, which are per member per month payments to community-based organizations for these joint programming. That kind of allows a steady flow of predictable funding between organizations that's different than sort of like a one-time lump sum to set up a program together. But this is another area where we need a lot more data and research to understand those models. The final big area here is how to structure these partnerships and work. We've seen 3 models kind of emerge in the field, and this harkens back to some of the very first early work I presented and showed at the beginning. The first is situating this work within a healthcare organization. So this would look like, often looks like a local healthcare system kind of developing work on integrating care, and that's sitting within the healthcare organization. The positives of this are that healthcare systems have a lot of capital and resources and existing structure to build into. So that can generally mean there is maybe more financing available. Even things like employees doing this work can sit in the healthcare system, and it's very easy to set up their benefits and their employment to kind of facilitate the work. The downsides are that this means kind of healthcare is running the show. At the end of the day, those employees report to a healthcare organization, and it situates a lot of power within the healthcare organization. A second model we see is a shared kind of umbrella organization that emerges where this would go to that kind of fully integrated model that I mentioned at the beginning. So this is kind of a coordinated organization of some form where the medical providers and social service providers all share in, there's a lot of different ways this can be set up, but sort of share power or membership in an umbrella organization that is directing both the work and the financing. The positives are this can set up kind of maybe a better power structure where imbalances in financing and power between community-based organizations and medical organizations can be kind of be more on level footing. The challenges are this essentially involves setting up new organizations, which is a lot of work. We've even heard, you know, once you set this up and you have a couple of employees you want to employ, then there's a whole bunch of work because you're sort of setting up a whole new HR structure to employ the people who will do the work. So there's challenges of that. The final is some kind of third-party convener. I'll talk about this a tiny bit more with policy, but choosing an organization in a local area who can be funded and responsible for building this network and doing this work. This could be this tends to be an existing organization. It could be a new organization that's formed just to do this. This shares a lot with the shared umbrella organization, but is usually kind of like a third party as opposed to everyone having a stake in it. And key issues, however this is done in structuring the work, is figuring out how to get people to work together that haven't before, including how to handle the disparate power and resources, and then critical questions about where staff are housed, who do they report to, and how to structure the work of boundary spanning, which is kind of an umbrella term for any work that has to happen across settings and organizations. My final couple slides here, I know I'm almost out of time. We don't really know much about how these partnerships are formed at large. So if you look at what is being done in this area, including by my team, but many other teams around the country, the formal term in the organizations literature, these would be called cross-sectoral alliances, because we're crossing sectors and they're independent organizations working together. There's a lot of theoretical lenses that could provide important insights into when these kinds of partnerships may be more successful or less successful, and help us understand where and why this work is happening to better predict what policy might work or not. This role of partnership selection is really important. In many cases, we've seen, even perhaps a decade ago, a lot of these kind of coalitions in a region of healthcare providers and social service agencies come together. We sometimes talk about that as like a solution in search of a problem, simply forming the coalition without having a clear set of goals or a clear target. A lot of times those can be formed and have very aspirational goals, but eventually dissolve because there's lack of funding, and it's hard to kind of hone in on more specific efforts. In contrast, there's much more targeted partnerships where you may have one community-based organization working with one healthcare organization to put together one program. And that's a much more like dyadic and small form of these partnerships. So figuring out kind of the success of these and the range of these is really important. And this is where we have a lot of empirical work, but it hasn't really been aggregated up to understand more these types of partnerships. And finally, this actually could speak back a lot to the existing more theoretical literature. There's a lot that healthcare has not contributed, and what we're seeing with healthcare and community-based organizations partnerships could speak to existing literatures and really expand the organizational theory in ways that would be important to that field. I want to get to the role of state policy and how that's also an underutilized area. A lot of states actually realize they want more of this happening and are putting policies in place to do it. I'm highlighting just 4 here, but there's many more to be done. Laboratory, my Y fell off the end. I think there's a lot to be studied in how states are structuring and incentivizing this work and what would work best. I'll highlight my state here in North Carolina. There's a lot of work in our Medicaid waiver to incentivize this work. And I'll point you to one in particular, which is the state is funding in each region one organization to coordinate building a network in the area, building a network of community-based organizations, and even doing some capacity building for community-based organizations that are historically underfunded. That's very different than, say, the Massachusetts or New York models, where the funding is really flowing to healthcare organizations and incentivizing the healthcare organizations to set up their own partnerships with community-based organizations. And some work on Massachusetts, for example, has shown that this model of kind of funding healthcare and having healthcare then be required to work with social services, we see that social service providers start to become more medicalized in their language and the way they develop care. And so we don't really know how that plays out for patient outcomes, but there's kind of like a lot that can be done in this area to study how these different state policies play out, and then which of those is most effective for actually improving outcomes. So just to return to kind of this larger question of who should do what, these are kind of the questions that I see in this field as still really unanswered, and so ready for more work. These are areas we're working on, and probably many of you are working on, so I'd be great to hear your all's feedback on this. Where should we screen for social risk factors and how often? Right now, almost everyone is trying to stand up their own screening. So health plans are screening patients, health systems are screening patients, primary care practices are screening patients. Social service agencies are screening patients. Do we need patients to be screened that much? Yes or no? What's the right place to screen? How often? How could we better share that data so as not to just be doing a lot of screening repeatedly over and over? What services should be provided within healthcare settings or within social service settings? A lot of times in healthcare, this is talked about integrating social services into healthcare, but there's probably a lot of case to be made for what would be called from the healthcare side, reverse integration, integrating medical care into existing other existing locations. So integrating healthcare into homeless shelters, into food banks, where people are already receiving social services rather than the other direction. How to best set up these partnerships between organizations, and how to build capacity in community-based social services and shift the money in healthcare where we know there's a ton of money in healthcare. How do we shift those funds upstream to the organizations doing this kind of work? So that is the end of what I have. And I will welcome all of your feedback and questions and comments that you have. And I think I will turn it over to Dr. Marsh for this.
Thank you. Thank you very much. What a great presentation, and what great data you have. I have many questions. I'm going to refer to our audience in the chat, and I strongly encourage everyone to use the chat. But we have a first question from Catherine Gasillo, who says, under the shared umbrella organization, you noted a problem was having to create a whole new setup within HR. Maybe I'm misunderstanding. Is this the same as having a community engagement public health person within the hospital who has the mindset of working at a community organization or nonprofit? Exactly. Talk some more about what that means.
Yeah. So I think I think if I understand your question correctly, there is a model where you might have a person within the hospital who in theory is working for maybe the community coalition. What we've actually seen when we're in the field is there are some organizations where they set up a new umbrella organization, and everyone is the existing healthcare and community-based organizations are all members of that new organization. And it's relatively easy to set up that new organization from the paperwork standpoint. But this organization actually wanted to hire employees. And that turned out to be a lot of work because they needed to pay the employees and set up a benefit structure. They ended up, so there's different ways you can structure it, but in that case, the organization spent essentially some staff for the organization to do just the organizational work, and then some staff for the organization to do more of the service delivery integration work. You might call it kind of care coordination across medical and social services. And they ended up kind of putting an agreement in place with one of their members that was a large healthcare organization where the employee technically was housed within that organization and got a computer and an email address through the healthcare organization, but was contracted out to the new umbrella organization. It's kind of a long answer, but I think the main problem is setting up a new organization is great in some regards and also tricky in the practicalities. And when you get to the devil in the details of a new organization, it can slow down the work a lot. I'm not sure that answered the question. If not, I'm happy to hear more.
Okay. And from Michelle Cow, we have, how do you see coordinated primary care startups like Oak Street Health, GenMed fitting into interorganizational partnerships? The Venn diagram that you showed us.
Yeah, that's a great question. I think I'd also put in that bucket, the one I'm more familiar with is City Block, where it's kind of a new integrated primary care model. I think I'm not super familiar with either of the ones you're mentioning. I'm a little bit familiar with Oak Street Health. I think a lot of times they are doing a lot in-house. They will still need to be, I think they're doing more in-house than most healthcare organizations would be doing in-house. So for example, a lot of times they will have care coordinators that are much more familiar with the local social services than a standard care coordinator that sits in a hospital system would be. They still will need to be kind of referring and checking with patients that they're referring out for other services. So for example, like patients that need housing and are working with local housing agencies. I think those startups tend to have a lot more time for the care coordinator type personnel to be doing their own follow-up to really, maybe you don't even need as much of a closed loop referral because they have so much personnel time dedicated to doing that work. But they still are needing to do, I think as they scale up, they will need a robust system to coordinate with those local organizations, unless they can kind of afford to put enough time into the personnel who can kind of patient navigate that work for them.
Okay, great. And from Geronimo Benharano, has there been thoughts on unintended consequences of addressing social structural at the individual level through the healthcare system? Medicalizing social problems, we might call that in social work. Most programs are means tested to ER users, Medicaid beneficiaries, or high utilizers, which could end up leaving people behind, yes?
Yes, this is a great question. I mentioned I'm trained as a sociologist. So I actually, like when I started my PhD, was studying residential segregation. So even I, sometimes when I look at this work, I'm like, our major problems are like, let's fix racial segregation. That will fix a lot of our other problems. Realistically, that's not the world we live in. I often tell a story of when I got most committed to figuring out the problems in healthcare was the city of Boston had budgeted $1 billion to additional dollars to its public education system for a 10-year period. They give they spend the $1 billion at the end of the 10-year period. They look at the effects of that. And it turned out all of the money had gone to increasing health insurance premiums for teachers and had been fully absorbed in kind of exploding healthcare cost growth. So I think it was such a lesson to me on how we think of social factors as upstream determinants, but healthcare itself is sucking so much of the money out of the system that it's preventing the work on the upstream determinants of health. So yes, I do think there's a lot of unintended consequences to get to your specific question. I think the first unintended consequence is this medicalization. We're seeing it in North Carolina. For example, Medicaid is testing a pilot to pay directly for particular evidence-based social needs, including paying for a certain number of months of rent for certain patients who qualify, paying for food boxes with Medicaid dollars for patients who qualify. As a result, it means places, for example, food banks need to be able to bill Medicaid. And so are having to set up billing processes and using the codes they need to use and to be able to bill Medicaid and get paid for that. So even in setting up those processes, we see that the social service organizations are becoming more medicalized. I mentioned there's a great study called Money Moves the Mayor in Milbank about Massachusetts and how money flowing through the healthcare organizations there has really led to community-based organizations even changing in their language to more kind of medicalized language. I think those are really important unintended consequences for us to keep in mind. Also, kind of the focus on specific populations is tricky. I think a lot of times the healthcare providers, when they're doing the work, recognize that, and they really don't want to develop programs that only can benefit some of their patients. They really want to just develop new programs and be able to have their patients all use them. So I think there's a lot of kind of devil in the details that ends up in these only certain patients can get access to certain services, while there is a lot of motivation on the part of providers not to have to do that. But I do think there's a lot of those unintended consequences.
Great, thank you. And from Armando Quinones Cruz, excellent presentation. I was wondering if you've been able to assess the role of managed care organization health insurers in identifying, addressing social needs, since they usually have teams of care managers, particularly with populations like Medicare and Medicaid. Is there any success with these programs?
This is an excellent question. I'm familiar with some of the programs, but I don't know that there's really any empirical literature looking at these yet. A couple of examples, like here in North Carolina, again, through our Medicaid waiver, the managed care plans are required to screen all of their members for social risks every year. And they're part of their payment from the state to the managed care plans is on that. There's also a couple of really interesting pilots that, like United Healthcare had a couple of really interesting pilots around housing, for example, in some of their Medicaid managed care plans. And I think all of the health plans are working in this space. We have a lot of students, for example, we have a joint MBA MSPH program. A lot of our students go into Medicaid managed care programs, and a lot of them are working specifically in social needs and social risks. We haven't seen a lot of data coming out or empirical evaluation of how those programs are going, what's most effective or not. So I think that would be a great area for more study. And it goes to that question of like, what can the role of these different organizations be? I think there is a role for health plans to facilitate some of this work outside of kind of the direct services, and that's not being fully tapped yet, although there are some pilots and experimenting.
Great, great answer. I think we have one more question, and I have a question before we end that I would like to ask you. To what extent do healthcare organizations have a multi-year roadmap for increasing effective multi-sectoral partnerships in the social sector? And if that roadmap exists, are CEO and senior leaders engaged and accountable for progress?
Excellent question. You could also read as, how good of a qualitative researcher are you, so that you really know what, are they really showing you what's going on? So I think most large healthcare organizations would say they certainly have a multi-year plan, a strategic plan in this area. I think when you get under the hood of that, those plans are often somewhat thin, or they sit in kind of one particular part of the organization and are not necessarily being prioritized throughout the organization. I think you see the rise, even in the last 2 years, the kind of resurgent interest in health equity or racial equity intersects with this work in addressing social needs. So you see the development of new positions or new offices within especially large healthcare systems focused on this work. We are, two of my colleagues I mentioned, I have started discussing this term symbolic compliance, and trying to tease out when organizations are kind of symbolically doing the work versus really in the trenches doing the work. And I do think there's a lot of organizations where senior leadership is not that they are not sympathetic, but I can't think of any we've interviewed where they are accountable for progress on this in particular. The closest might be Minnesota's, I'm just thinking on the fly here. Minnesota has a payment program called the Integrated Health Partnerships. And that program, healthcare organizations participating are required to develop and test new interventions to address health disparities. And they typically are focused on they're almost all focused on social determinants of health. And if they kind of don't, they have to kind of demonstrate their progress on that as part of their payments under this payment program. And if they don't receive all of the payment. So that would be the closest, but it's really the organization level. It's not necessarily the senior leadership that's on the hook for that. It's kind of the organization won't get paid all of their Medicaid payments if they don't. But it's a great question. It might be a great lever to make this work more meaningful and impactful.
I agree. That's a great question. And it's related to my question, which you pointed out that where the money is really in the healthcare sector, and probably we can summarize what you've talked about as the drivers for this integrated service really has come from the healthcare sector. So there's actually a very strong, active group of social service providers, academics, researchers who are asking these same questions and asking what are the strategies, what are the levers that come out of our field that can help us move this process forward more effectively. And if we were to go back to the model that you provided, where we can look at payments, we can look at data, we can start with programs and services. Do you have thoughts about where the social service community should put its emphasis?
Ooh, good question. You mean the I'm going to pull it back up.
You provide a nice roadmap or model in terms of how do we move this forward, and so. Of those, all of those are critical, obviously, but in terms of advocacy, involvement, research, where should the social service research community put its expertise in?
Yeah, and I will say that community has been doing this work far longer. Like when we were first writing grants in this area, that was the literature we were citing, was kind of the social services work, because it's no surprise to anyone working in that field that the lack of integration is not helpful to patients. I think the joint programming interventions and the kind of referrals and closed loop referrals is the area where everyone wants to be. That's really where people want to advance. I think, the data and technology are important. I think I personally can only study like health IT so much before I start to get glazed over. So I think the people that want to work in that field is great. I think the community you're talking about, kind of helping think through what these joint programs can look like, when are they best served, kind of as like one-off small programs versus larger, more integrated programs. Like when do you set up a really limited program like the one I discussed about, hospital discharges and reserving some space in the public housing for those. That would be like a really tiny program, versus there's some programs that are like really large and comprehensive and intended to be much wider scale and address a wide set of needs. I think if we can develop a couple of models, even theoretical, I don't want to call them theoretical, but a kind of like ways these programs can be developed, a small scale program, a medium scale, a large scale one. What does governance look for those? What are financing models look for those? How can you structure the work for those? That would be really valuable to the field. And a lot of that work is happening, but like I said, it's kind of all one-off, and there hasn't been kind of congealing around, if I'm a organization who wants to start in this work, when I approach the literature, there's like 1,000 pilots, and it's a little hard to navigate, like which one would be right for me and why, and what, there's not kind of a more, I don't want to say a manual, but that's where I think of when I think of the conceptual and theoretical side contributing. We haven't really like aggregated the knowledge enough to help guide practitioners or researchers working in the area. So that's probably where I would go. But I'm curious, like from that community, the response to this kind of work, which really does approach it from the healthcare angle.
So the other challenge, I think, from the social service sector side is that we're interested in integrated services that not just between social services and health, but social services and mental health, social services and child welfare, and the kinds of challenges and models that you describe, I think, are quite relevant across all of those cross-sectoral relations. So with that, I will thank you very much for joining us today, Valerie. It was a fabulous presentation of great interest to our work here in Chicago at CHAZ, and I hope we will stay in contact. Thank you.
Thank you so much. Thank you everyone for attending.
Okay.